Now that both ambulance services in our system have AutoPulse, we wanted to provide some additional training to all of our members on the use of this very important device. The AutoPulse benefits: it provides a very highly consistent compression rate and depth, more consistent in its rate and more consistent in its depth than manual CPR. It provides a circumferential compression in that it squeezes around the patient rather than just in one spot on the anterior chest, as this band detaches with Velcro and the patient is laid on the device, and then the band reaches around, and the machine provides this circumferential compression, which has been proven to be very effective. And what we're seeing is very few rib fractures with the machine. Now, obviously, there will be some with manual CPR, but this provides a much safer, for us, but more importantly, a more effective method of doing compressions during transport. It's well known that our CPR loses effectiveness as we begin to move, and so the AutoPulse helps with that. That was the good stuff. Here's the other stuff. It's a battery-powered device, and so when something operates on batteries, there's an opportunity for failure. Now, the initial experience we had here locally with batteries was very poor. There have been significant changes and improvements, and we haven't seen problems recently from the batteries, although it's a battery-operated device, and so we always have to pay attention to that. The other knock on any of these mechanical CPR devices was that there was going to be some interruption in CPR to apply, and as part of this training, we can prove that with a little bit of practice, we can be at 10 seconds or less interruption, and we would submit that there are many other things that interrupt CPR, and the application of the mechanical CPR device, the AutoPulse, is not one of them anymore. The patient does need to be secured with the straps that come with the AutoPulse. That patient will move around, and the load sensor here, the black device that's on the AutoPulse, that's how it senses where the patient is and adjusts its compressions. And so if the patient has moved off to the side, then the device will give an error until we can get the patient back on. So there's some straps that hook on to those two loops, and then the two bars down to the side. It's important that we use those. And a cervical collar will be helpful to keep the patient's head from moving around. And as we mentioned before, we're not out of the woods with rib fractures, because our manual CPR will most certainly create some rib fractures. So our folks don't need to know how to use the device. But fire district folks need to be able to help apply the device. The controls up here at the top, those are operated by the ALS unit. The most they may ask us to do is, hey, push the green button or push the orange button. Here's the strap hooks that I talked about before, and it does matter which way the patient goes on there, so there's a marking for where the head should go, and that's kind of the anatomy of the AutoPulse. Here's the controls, and it's a matter of functions with pushing the green or pushing the orange. The device can go to continuous compressions, which we should use, not can use, but should use once the patient has an advanced airway in place. Advanced airway in this definition includes combi tube or ET tube. So that's one of the times we'll be interacting with it, and then a couple times during the arrest you may want to pause briefly to see what's the underlying EKG rhythm is, and so the ALS crew may ask you to push the orange button or push the green button, that sort of thing. Patient prep we can do. I've got kind of a cut sequence here on a shirt. We'd like to go right up the middle, and then we'd like to catch where that was and go right down one sleeve, so that you can rapidly and easily remove the shirt as the patient is raised up. We would also like, although it's got nothing to do with the AutoPulse, we'd also like to be prepping our patients by exposing both legs below the knee for placement of the interosseous, the EZ-IO, which is a route for medication delivery. So we would like our patients to have no clothes on from the waist up or from the knees down in order to assist ALS crews as they arrive. Another thing that's going to come around and be more and more popular will be the use of soft stretchers, or the slang around here is the tarp. But the soft stretchers work much better around corners and stairs. You can drop legs down and shorten the patient, and maneuvering the patient with the AutoPulse is much better than it is when you try to put them on a spine board. The AutoPulse does not slide around at all on this tarp. So I think that's what you're going to see as we move forward here, and it's being recommended strongly by the manufacturer of the AutoPulse and the ambulance services. So we made a little training prop out of a CPR board, and we'll be bringing that around as best we can with EMS training and some borrowed devices as well to give our folks a chance to be oriented to this device, to the very few things that we need to be able to do. The majority of it is rapid placement, and that involves setting the patient up. Log rolling the patient is no longer our best method when we're using AutoPulse. We need to set the patient up and have their clothes removed quickly and get them back down. And we have a video that shows about that.
This video will demonstrate how to prepare the cardiac arrest patient for the arrival of ALS providers and the Zoll AutoPulse. Beyond CPR, we also need to prepare the patient by removing any clothing above the waist, including cutting the sleeves of any long sleeve shirts, and exposing the legs below the knee. So if they're wearing jeans or long pants, that need to be cut up to the level of at least the knee. As ALS units arrive, one member will be responsible for deploying the AutoPulse, while the other member will usually handle all the other ALS equipment, including the Zoll E-Series monitor defibrillator, hooking that up to the patient, and also preparing for a medication route. Once the AutoPulse is ready to deploy, the patient will need to be set up, the AutoPulse placed behind the patient, and the patient lowered back down onto the AutoPulse. All of this needs to be completed while limiting the interruption in chest compressions to no more than 10 seconds. The patient may need to be repositioned on the board to be in the appropriate spot. There is an outline on the AutoPulse that will help guide you in aligning the patient on the board appropriately. The life band is then reattached in the front of the patient, and the AutoPulse is turned on and compressions are taken over by the AutoPulse. A C-collar is also placed on the patient to help immobilize the head. The chest straps that come with the Zoll AutoPulse are designed to attach to the board in designated spots and are used to secure the upper body to limit motion during transport. The preferred method of moving this patient would be with the tarp, placing the patient and the AutoPulse in the tarp and carrying them to the cot. It is not recommended to use a long spine board for this.